Hello, I'm Peter Hotez. I'm an MD PhD pediatric vaccine scientist working to develop low-cost vaccines for global health. Our group at Texas Children's Hospital Center for Vaccine Development developed two COVID technologies that were administered to 100 million people in India and Indonesia. We also developed vaccines for parasitic infections, including a human hookworm vaccine that we hope will be available soon. And I want to share some insights on the critical issues surrounding global vaccine access, drawing attention to the dual challenges of inequity and hesitancy. As is well known, the world faced a severe lack of access to COVID-19 vaccines, and it's crucial to delve into the well-discussed issues of inequities and the often overlooked problem of vaccine refusal or hesitancy. First, let's talk about global vaccine inequities. Low and middle income countries face significant challenges due to science policies that prioritize speed and innovation, limiting their ability to produce vaccines. From my point of view, there was a science policy failure. We were so focused on speed and innovation and getting some very interesting mRNA and particle vaccines. But as any engineer will tell you, when you focus exclusively on speed and innovation, there's a learning curve before you can go from zero to the 15 billion doses of COVID vaccines that were required. And so the political identities and causes behind these inequities must be addressed to ensure improved global access. And then shifting to the second component around vaccine refusal or hesitancy in the United States, especially in Texas, where I reside and work, thousands of unvaccinated individuals perished due to the growing anti-vaccine, anti-science ecosystem. And my commentary sheds light on vaccine hesitancy in the US and India and Brazil, emphasizing the impact of political and societal factors on vaccine acceptance. Now, to address both of these issues, vaccine inequalities due to lack of production and access, and vaccine hesitancy. So, to address these issues, I propose a two-part fix. First, achieving equity through a low and middle income country vaccine production is essential. So, for instance, we transferred our technology for two COVID vaccines to India and Indonesia, to Biological E in India, to Biopharma in Indonesia, and 100 million doses were administered, providing proof of concept that it's possible to bypass the big pharma companies. It's not to demonize the big pharma companies, but we need alternative models, and I think we provided proof of concept for that. So we need to foster partnerships and provide support to vaccine producers in these regions, promoting local production for timely access to vaccines. And the second part involves tackling vaccine refusal and hesitancy. The commentary discusses the politicization of vaccines and the rise of anti-vaccine activism, particularly in the English-speaking world. A comprehensive approach is needed involving major global leaders, governments, and international bodies to counter the influence of rising anti-vaccine activism. In the US, 200,000 Americans needlessly perished because they refused a COVID vaccine during our Delta and BA1 wave, very much along a partisan divide. And now that US-style form of anti-vaccine activism is now globalizing. So, in conclusion, urgent attention is required at the United Nations and other international forums to address both vaccine equity and hesitancy. These issues should be treated with the same urgency as other global health crises, considering the broader implications for global health, the economy, and international security. And together, we must work towards ensuring widespread vaccine access and acceptance.